complex tachycardia, procainamide is the antiarrhythmic of choice for stable patient. So remember, if you have a stable patient with wide complex tachycardia, use procainamide. What to do in a patient who has a stable narrow complex tachycardia? First, we need to know whether the patient has a regular or irregular rhythm. As we know, if it is a narrow complex plus irregular, it is either atrial fibrillation, atrial flutter with variable block, and multifocal atrial tachycardia. So if irregular is there, you are not going to perform vagal maneuver. You need to control rate. Why we don't do this is because it's a very important concept. So in irregular tachycardia, mostly AF, flutter with block, and MAT is there. The rhythm is not AV node dependent because there is some other there are multiple foci in the atria which are acting as a pacemaker. So the rhythm is not, there is no re-entrant circuit acting, and the vagal maneuver actually slows down the AV system, AV node. So slowing the AV node is not going to help in that tachycardia. Plus, if the patient has AF with WPW, then we perform a vagal maneuver in AF with WPW, it is going to slow down the AV node conduction, then converting that WPW into a fatal VF for rapid ventricular response, and it can lead to killing of the patient. So in AF patient or any irregular narrow complex tachycardia, do not attempt vagal maneuvers. So what we need to do? Control the rate with diltiazem or beta blocker. Use beta blocker with caution in pulmonary disease or CHF or asthma. Treat underlying cause. Consider expert consultation. AVRT में P waves are after QRS and there are retrograde P waves. What is the difference between AVRT and AVNRT? सो AV NRT में जो रीएंट्रेंट सर्किट है वो N आ रहा है ना, AV NRT. सो AV नोडल रीएंट्रेंट tachycardia. So the reentrant circuit is located inside the AV node completely. There is no accessory pathway. While AVRT, there is some AV node involvement plus accessory pathways there. And most commonly SVT are AV nodal reentrant tachycardia. That's why nodal blocking agent like adenosine works so well in supraventricular tachycardia. The P wave is hidden in AVNRT. The baseline ECG is normal. The risk of AF is rare, and ablation target is a slow pathway. In AVRT, the P wave may be visible after QRS, and retrograde P waves can also be there. While in AVNRT, you will not be able to see P waves. In WPW, AVRT occurs because we know in WPW there is an accessory pathway, है ना? So we don't block the AV node because we want some normal conduction to happen. Otherwise, the accessory pathway will take over and patient will have fatal tachyarrhythmias. So what to do? The patient has regular supraventricular regular narrow complex tachycardia which is stable. You can attempt vagal maneuvers. You can give adenosine 6 mg IV push, then 12 mg IV push. If it still doesn't convert, we can repeat a 12 mg IV dose. If it converts, it was probably AV nodal reentrant tachycardia or AVRT. Observe the monitor. Repeat adenosine and control rate with blocking agents like diltiazem and beta blockers. So convert अगर हो जाएगा तो हम क्या करेंगे? ऑब्जर्व करेंगे, मॉनिटर करेंगे और रेट कंट्रोल करेंगे diltiazem और बीटा ब्लॉकर से. If the patient does not convert, there is still tachycardia. It is possible atrial flutter or ectopic atrial tachycardia or junctional tachycardia. We can just control the rate with diltiazem or beta blocker. And beta blocker like pulmonary asthma CHF में ध्यान रखना है. Treat the underlying cause and call cardiology. If we have a patient with stable wide complex tachycardia, first we need to know if it is a regular or irregular rhythm. If it is regular, it's most likely monomorphic VF or SVT with aberrancy. If it is irregular, it is polymorphic VT or SVT with aberrancy. Any regular SVT with aberrancy will cause regular wide complex, and irregular SVT with aberrancy will cause irregular wide complex. If the patient has regular tachycardia and if ventricular tachycardia or some uncertain rhythm is there, provide antiarrhythmic treatment with procainamide or amiodarone. 20 to 50 mg per minute procainamide is provided. Procainamide is drug of choice in stable wide complex tachycardia, but it cannot be used in a structurally abnormal heart. So amiodarone is given blindly if we do not know about the patient has past CAD, any ischemic heart disease or some structural heart disease or not. If we don't know that, it's better to avoid procainamide and proceed with amiodarone. You can also prepare the patient for synchronized cardioversion if the patient may become unstable, as giving the antiarrhythmic drugs will decrease the energy required for cardioversion. If the patient is known SVT with aberrancy, then only you are going to give adenosine. Okay? If the patient has irregular tachycardia, if there is pre-excitation with AF with WPW, you are not going to perform any vagal maneuvers or not going to give any beta blocker, calcium channel blocker or adenosine to the patient. Consider antiarrhythmics in AF with WPW only amiodarone and procainamide. So what can be given in AF with WPW is amiodarone and procainamide. If the patient has torsades de pointes, give magnesium 2 gram IV over 2 minutes and then 2 gram per hour infusion. Consider expert. Like if polymorphic VT is there, drugs are not going to help. Prepare for synchronized cardioversion. If AF with aberrancy is there, then you need to just do rate control. Follow the narrow complex protocol. This is an ECG with premature atrial contractions. You know, some P waves are occurring fast, like this is the P and then QRS is there. So prematurely the atria is contracting following a QRS. कुछ नहीं करना है इसमें. So it may be premature atrial contraction originate from ectopic pacemaker anywhere in the atrium other than the SA node. There is a characteristic ECG feature like ectopic P wave may not be conducted through the AV node if the premature atrial contraction reaches the AV node during the absolute refractory period. So you may find some P waves that are not conducted. When a PAC reaches the AV node during the it may be conducted with a delay sometimes. Most PACs are normal. There are normal findings in all ages. Nothing needs to be done, but frequent PACs are associated with increased risk of stroke and sudden death. So you need to be watchful for this patient, that's all. What are the ECG features of PAC? So P waves will appear sooner than the accepted sinus speed, varying shapes and sizes, and there can be a non-compensatory pause also. So interval between normal P wave is less than twice the existing P2P cycle, and I don't know what that is, and it's not even important, it's not pathological, and doesn't need to be treated, forget about it. What are premature ventricular contraction, VPC or PVC as you want to call it? This is the ventricular contraction. It's ventricular in origin. Why? Because it's broad and we cannot see a P wave before it, so it's not sinus. So you can see there are multiple ventricular contractions. More than equal 3 VPCs in a row is ventricular tachycardia. What is ventricular bigeminy? So every second pulse is a VT. And what is ventricular trigeminy? Every third pulse is a VT. For example, 1, 2, 3, third pulse is a VT. 1, 2, 3, third pulse is a VT. What are the ECG features of premature ventricular contraction? So there is no P wave prior to the QRS complex. There is occasional retrograde P wave after the QRS complex. Wide होगा और एक compensatory post ectopic pause भी मिल सकता है. ST segment and T waves are diuretic opposite of the QRS deflection. For example, if the QRS is upgoing, your ST and T will go down. If the QRS is down, your ST and T will go up in VPC. So what are capture beats and fusion beats? Fusion beats are hybrid complexes when there is a simultaneous activation of the ventricle by the sinus impulse जो ऊपर से आ रहा है और जो ventricle का खुद का impulse है वो दोनों ventricle को एक साथ excite कर रहे हैं. तो जो आपको wave मिलेगी वो will be a fusion beat. Capture beat होती है because during a VT you know that ventricle is the primary cause of the pulse. Ventricle is exciting itself and contracting also, so we have wide complexes and tachycardia. But capture beat occurs when the sinus, क्योंकि sinus node तो अपनी firing कर ही रहा है ना, when a sinus impulse successfully depolarizes the ventricle during VT, then it produces a completely normal looking QRS in a strip of VT. So we will show it. So कैप्चर बीट देख रहे हो, यहाँ पे VT चल रहा है, वाइड कॉम्प्लेक्स QRS चल रहा है, लेकिन सडनली अ नॉर्मल QRS इज सीन. दिस इज कैप्चर बीट. वाइल अ फ्यूजन बीट विल बी लाइक ब्रॉड समवॉट अपराइट. तो मतलब फ्यूजन बीट दोनों का कॉम्बिनेशन होगा. ठीक है, कैप्चर बीट इज लाइक अ स्ट्रिप ऑफ VT में आपको नॉर्मल QRS दिख जाए, दैट इज कैप्चर बीट. फ्यूजन बीट विल बी मतलब फ्यूजन बीट विल बी काइंड ऑफ लाइक अ नॉर्मल. वो नॉर्मल बना नहीं है, टोटल ब्रॉड है, थोड़ा सा अजीब है. इफ द पेशेंट हैज़ फ्रीक्वेंट VPCs फॉर more than 30 months, the patient can develop VPC induced cardiomyopathy. And VPCs can cause R on T phenomena causing VT. So frequent VPCs are dangerous. They can make the patient go into VT. VPCs initiate VT. So remember, R on T phenomena produces VT. Next we will read about bradyarrhythmias. So first ECG is a junctional rhythm. As you can see, there are no normal P waves. It is a junctional rhythm with no P waves. है ना? This is not a P. Remember it. P proper आता है. Okay, so this is a junctional rhythm with no normal P waves, and this is a junctional rhythm with retrograde P waves. Junctional bradycardia. What are the ECG features of junctional rhythm? So we see bradycardia. Between 40 to 60 pulse is required for junctional bradycardia. If the pulse is between 60 to 100, it is accelerated junctional rhythm. More than 100 is junctional tachycardia. So we will not see normal P waves in junctional rhythm. We can rarely see some retrograde P waves, and there will be narrow QRS complex. Next is idioventricular rhythm. So idioventricular rhythm originate from the ventricles. They have a wide QRS and the rate is between 30 to 50. If the rate is between 50 to 100, then it is accelerated idioventricular rhythm seen in reperfusion after STEMI. So this is classically an idioventricular rhythm. It is kind of broad, originating from ventricles. There is no P wave. What are the ECG features of idioventricular rhythm? It is going to be a wide regular pulse with no P wave. Rate between 50 to 100 is called accelerated idioventricular rhythm. What are the clinical significance? It is seen in reperfusion in STEMI. It is caused by drugs like cocaine and digoxin, seen in hyperkalemia. You can find any ECG finding in hyperkalemia. Motto of today is, do not treat idioventricular rhythm. It is temporary, transient, let it come. Okay? Because if you suppress it with some antiarrhythmic agent, it will lead to asystole. So you're basically killing the patient by suppressing the idioventricular rhythm. You need to know how AF with WPW looks like. It is irregular with slightly wide QRS. and it's tachycardia, irregular tachycardia with slightly wide QRS. And if you can appreciate, there is some slurring when the QRS come. It doesn't come in a 90 degree. There is some slurring when the QRS is starting. What are the features of atrial fibrillation? Absent P waves with flat or chaotic isoelectric baseline. QRS are narrow and irregular ventricular rhythm. Wide QRS in AF can occur if AF with bundle branch block or AF with WPW, called pre-excitation syndrome. What are the ECG features of atrial flutter? You will have identifiable P waves, but they will be in a sawtooth morphology. Okay, and it is regular, usually 300 beats, and there is some like 3 P waves followed by 1 QRS sort of thing. QRS complexes are narrow unless there is pre-existing bundle branch block, and ventricles rate is regular. Sometimes irregularity may be seen, but is mostly regular. Ventricular rate is often 150 beats per minute due to a 2:1 AV nodal block. Now, a very important score, Chad's VASC score, you can also call it Chatu DS2 VASC score. Chatu DS2 VASC. So जिनके आगे 2 लगा है, they will get 2 points. Rest of the things, if they are present, they will get 1 point. C says CHF. If the patient has CHF, 1 point. Hypertension, 1 point. Age more than 75, 2 points. Diabetes, 1 point. Stroke, 2 point. Some vascular abnormality, 1 point. Sex is female, 1 point. And age between 65 to 74, then 1 point. If the patient has a Chad's VASC score of more than equal to, you need to start anticoagulation. The goal INR is typically 2.5 to 3.5 for mechanical prosthetic valves or mitral stenosis. We are going to use warfarin in mitral stenosis and prosthetic valves. Rest all we can use novel oral anticoagulants. The goal for rate control is ventricular rate of less than 100 beats per minute at rest. We can use electrical cardioversion using 150 to 200 joule to ablate the atrial fibrillation. It is more likely to ablate if the atrial fibrillation is of short duration, typically less than 48 hours. So what are the pericardioversion anticoagulation we will use? So we will divide it in valvular AF and non-valvular AF. If the patient has non-valvular AF and the onset of AF is more than 48 hours or unknown, or the patient has stroke or transient ischemic attack in less than 6 months, or Chad's VASC score is more than 2, more than equal to, we will use normal oral anticoagulants like apixaban, rivaroxaban, dabigatran. Apixaban, rivaroxaban are factor 10A inhibitors, and dabigatran is direct thrombin inhibitors. If valvular AF is there, means rheumatic mitral stenosis or mechanical prosthetic valve, we will use enoxaparin or warfarin.